Hi everyone, welcome to Ask the Ivf Whisper. Always so excited to come on and talk to you guys and answer your questions. I'm just humbled by all you guys who reach out wanting to get my opinion about your case. And I just have to always say this at the beginning, that my opinions are not in place of medical advice. I promise you your doctor knows more about you than I do, but it's just always so fun to get to hear from you and share my perspective, because there's really nothing I love to do more than talk about fertility. My husband often sees me sitting down on a couch and he's like, "You're thinking about getting someone pregnant right now, aren't you?" I'm like, "Yep, you got that right. I certainly am." So thanks for joining tonight, and let's get started. This is Alexandria. She's 45 years old from Greece. And she says, "I'm about to start my IVF cycle in a couple of weeks. I'm giving it one try. My doctor prescribed Gonal F 450 for the first 4 days, and it sounds to me like a very high dose. I know that in some countries the maximum dose they give is 300 units. I read that older eggs tend not to like such high doses of gonadotropin. I would love to hear your opinion. Thank you." So Alexandria, in my opinion, 450 is a really healthy dose. I don't think that it's too high of a dose. However, depending on the number of eggs that you have, it might be totally unnecessary. So here's the deal. If you have, let's say, 10 follicles, 450 would be a great dose to get all 10 to grow. If you have, let's say, 2 or 3 follicles, I'm not sure you necessarily need 450 to get 2 or 3 to grow. So I take a look at your body size, your follicle count, your previous fertility history, and how you responded on meds previously, and then make a decision as to what the best dose is for you. But I don't think 450 is too much. I don't think you'll fry your eggs. However, if you have a low number of eggs, which is totally normal at 45, you may want to consider a combination of fertility pills with injections. I call that a hybrid cycle, and that's something that I like to do quite a bit of. This next question comes from Isha, 32 years old from India. My husband and I started trying in January 2020 and conceived in July. However, in our first viability scan, we found that the baby had no heartbeat, and I had to take misoprostol to pass the pregnancy. We got the following tests done after this loss. AMH was 6.65, prolactin 17, LH5, FSH 4.75. My pelvic ultrasound was totally normal, and then we conceived again. This time, however, in February of 2021, it was an ectopic pregnancy. I took a methotrexate shot February 26th. My HCG went back to below 2 on March 20th. I'm waiting for my first period for a repeat scan and to discuss the next steps with my doctor. One thing she suggested was an endometrial biopsy and hysteroscopy after the ectopic mass resolved. Is there anything else you would suggest? I'm sorry, Isha, that just sounds horrible, that in the last year that you would have not just a miscarriage, but also an ectopic, and then on top of that, everything that's going on in the world with COVID. So I'm really sorry that you've had these experiences. And there's just something really special about fertility patients right now who are still doing everything they're doing to grow their families in the current climate that we're in. So I'm sorry. My thought process with what you've been through is I do like what your doctor is thinking about. My gut is that there could be something anatomic. There could be something related to your fallopian tube, obviously, and that's why you might have been at higher risk for an ectopic pregnancy. I also think that when you might have a tubal issue, sometimes that could be due to endometriosis, and we know that endometriosis in a lot of women has a lot to do with adenomyosis as well. So I would ask your doctor if she is suspicious that you might have adenomyosis too. If you're doing a hysteroscopy, you might want to ask your doctor if maybe a laparoscopy would be helpful as well. So at the same time, she can take a look at both fallopian tubes, do a tubal dye study, and see if there's anything going on. Your egg numbers seem really reassuring, and that's really good at 32 to see such a nice AMH level. So that just gives me a lot of hope that you should have a healthy pregnancy in the near future. I created a checklist, and I know you guys know that I'm all about those checklists, so it's called the ANGEL method or ANGEL checklist, and those are all the things that I have patients consider when they've had a miscarriage, and it's just about looking at the anatomy of the uterus, your AMH, any adhesions or scar tissue inside the uterus, thinking about autoimmune issues, antiphospholipid antibody syndrome, for example, looking at your nutrition, genetics, chromosome analysis, sperm DNA fragmentation, looking at any possibility for an endocrine issue like a thyroid problem, and then looking at your lifestyle, like avoiding smoking and hard liquor. But wine is fine because it rhymes with dine, and I know that sounds really stupid, and I'm just trying to be funny here when this is obviously not funny. So thank you, Isha, for sharing your story with me. It's one that I hear all too frequently, and I hope that my suggestions will help. And then also, if you're not taking CoQ10, do consider taking it, as while your age is young, your eggs plenty, taking CoQ10 might help with egg quality down the road. This next question comes from Shirley. Shirley is 40 years old from New York. Hi, Dr. Amy. I've been following your shows on YouTube, which are very informative and helpful. Thank you. I'm 40. I failed 3 IUIs. I had 3 IVFs in the past 2 years as well. First IVF, 9 eggs retrieved, 5 matured, 2 formed blasts, and both were low mosaics. Second IVF, 11 eggs retrieved, 7 matured, 6 formed blasts, 2 normals, 1 low mosaic. I transferred 1 5A normal in July and failed. I transferred 2 low mosaics in September and got pregnant. However, no heartbeat was found. Week 6, my doctor had to give me mifepristone. January of 2021, I had my third IVF, 13 eggs retrieved, 11 mature, 5 blasts. I had 2 normal embryos, 1 low mosaic. My AMH is 3, follicle count 10 to 12. For all my IVFs, I started birth control pills a month before, treated with Follistim, Menopur 300, 150, then added Ganirelix on top of that for another 3 days, total of 6 days, then with a trigger shot, 10,000 units of Pregnal on day 7. Why is my retrieval course so much shorter than others? Any modification needed for optimization? I just had a hysteroscopy 2 months ago with a 1 centimeter polyp removed. Now I have 3 normal embryos, 2 mosaics left. I want to have 2 to 3 kids. What should I do next? More tests, embryo transfer versus another round of IVF? Thank you very much. I look forward to your reply. So let's go through some of your questions here. So question number 1 is, why is my retrieval course so much shorter than others? So you're right. Triggering on treatment day 7 is a little bit on the shorter side. I have, however, had patients who have triggered on day 7 to make beautiful embryos just like you. The thing is this, you're making mature eggs, they're turning into gorgeous blastocysts, they have normal chromosomes, so it does seem that your eggs are mature treatment day 7. So I'm not really worried too much about that, but you're right, it is a little bit on the shorter side of things. The next question you ask, any modification needed for optimization? One of the things I like to do is look and see if you might have silent endometriosis. With the number of cycles that you've been through, I want to make sure that we shouldn't consider another protocol to help you have a healthy pregnancy. With the 1 miscarriage that you had, even though it was from a mosaic, I'm still going to go through my angel checklist for you. And it seems like you ruled out scar tissue by doing that hysteroscopy and removing the polyp. But I think that if you haven't done an endometrial biopsy, perhaps for the Receptiva DX test, that is one thing that I would have you consider. You had implantation, so the ERA test may not be as helpful for you, but it's still something that we would consider talking about. If you haven't looked at your fallopian tubes, I know that sounds silly after everything you've been through to look at that, but that is still something that I like to consider, and that's doing the hysterosalpingogram. I do find that sometimes when the patient has a dilated fallopian tube, that can certainly get in my way for a healthy implantation. Since you want 2 to 3 kids with the number of blastocysts that you have, I would say that it may not be a bad idea to consider 1 more cycle of IVF to get 1 more normal embryo for you, and hopefully you'll get that at least. With the transfers that you've been doing, I would ask your doctor to consider potentially adding, and I know not everyone agrees with me on this one, so your doctor might say, no, I don't agree, but one thing to consider doing is adding Lovenox, which is a blood thinner, and I usually start it 2 days before transfer until the heartbeat ultrasound, and then I stop it if there's no evidence that you might need it. So part of the angel checklist is looking at antiphospholipid antibodies, anticardiolipin antibody, for example, and beta-2-glycoprotein to see if using a blood thinner would be beneficial for you. So I hope, Shirley, this all helps, and I don't think that you would regret doing a 4th cycle, especially if you want 3 kids. I always plan my patients' fertility roadmaps, or their road to fertility success. I just came up with that line right now, based on the age that they're going to be when they're having their last child. So if you're starting at 40 and you're going to want 3 kids, let's just say 3 times 2, you'll be 46 when you have your 40, when you're going to have your 3rd baby. Then I want to make sure that you have enough embryos for that age. So this next question comes from Natalie, age 33 in Texas. Would you recommend surgery to correct a septum for someone who has never been pregnant? And the answer is absolutely yes. Part of your question was a septum or bicornuate uterus, and part of doing a surgery would also be to get an adequate and accurate diagnosis. It's hard to imagine that you can go into surgery and not know what you're going to operate on, and I don't think any patient should wake up not knowing not knowing what could potentially be done. We have enough diagnostic testing now that you can have, let's say, a 3D, 4D ultrasound, an HSG, for example, to guide your doctor. And if they're still not sure if it's septum or bicornuate, they can also do a pelvic MRI. But part of doing that kind of surgery is a hysteroscopy where you're looking from below and then you can cut, that's not really what the scissors look like, but you can remove a septum. And then at the same time, it is a known fact that people who have a uterine septum or a uterine anomaly, like even a bicornuate, could have a higher risk of having endometriosis. So when I have a patient who has septum surgery, I often ask them to also consider doing a laparoscopy at the same time so you can remove any possible endometriosis and get an accurate diagnosis as well. This next question comes from Allison, age 35 in Texas. I had 3 embryo transfers in the last year, 2 failed implantations and 1 miscarriage. I have blocked tubes and I'm antiphospholipid antibody positive. My doctor wants to do an ERA and Receptiva DX test to rule out endometriosis. Should I get the diagnosis prior to the next egg retrieval? And if I do have endometriosis, should I be treated before my egg retrieval? My recent AMH was 1.4. My recent retrieval, I was able to produce 5 blastocysts, but only 3 passed PGT testing. All 3 eggs had morphology of 5BA. Does endometriosis affect egg quality? Thank you, Dr. Amy, for the future advice. So Allison, I'm actually quite reassured by your embryo quality, which means that I'm reassured by your egg quality. It is very possible that inflammation is affecting your implantation success. I don't know that you necessarily need the Receptiva DX test. I think that with your history of having blocked tubes, I think you can go right to laparoscopy potentially. However, if your doctor feels like ERA is something that you need, I would strongly suggest doing that. Since you had a miscarriage, it seems that probably that window of implantation that you, or that protocol that you used of progesterone to get you to transfer is probably the right window for you. One of the things that you can consider doing that I do for my patients is when I put you through that mock cycle, what I'll do is on the day of the biopsy, rather than doing a biopsy here in my office, we would book it as a hysteroscopy laparoscopy procedure in a case like yours where you're asleep, I do the biopsy, and then I put the camera in, do the hysteroscopy, and then do the laparoscopy all at the same time. So we're just not waiting for, more time to pass, and that time to pass just, feels like forever. I really wish I can invent something. Maybe I will one day, we'll see, where you actually don't have to wait until you ovulate. You can actually get pregnant every single day. Wouldn't that be incredible if there was like a drug you could take and then you can ovulate and then find out the next day if you're pregnant or not. And then if you're not, then you can do it again rather than like waiting for it and waiting for it. I'm telling you, this waiting, it's painful. This next question comes from Emily, 31 in Minnesota. I tested CMV negative, but the donor we love is CMV positive. I'm planning on starting with IUI. Is it a bad idea to move forward with this donor? Note, I'm using a sperm from the sperm bank. So again, my recommendations may be different from your fertility doctor, so please listen to your fertility doctor. But when it comes to CMV status, I tell my patients, forget about it. If CMV status was actually a thing, you can imagine that heterosexual people who were trying to get pregnant and have a baby would test the CMV status of each other before they got pregnant. So it is not dangerous to use a CMV discordant donor. The CMV testing, I think, is quite arbitrary. It's brought over from organ donation into the sperm bank world, and I don't think that it's something that needs to be involved in your decision to choose a donor. So this is what I was taught in fertility school, and this is how I practice. However, your doctor might have different feelings about it. So do ask your doctor and listen to your doctor. Don't listen to me, but you can bring up what I said. This next question comes from Jen, age 45 in Europe. I'm 45 years old and I had 2 early miscarriages in week 10 and week 11 in 2018. Last year, an ultrasound scan showed 3 small 5 millimeter or less solid objects in the uterus wall, which cannot be seen during hysteroscopy, but clearly seen on vaginal ultrasound. My OB/GYN advised me to ignore it since she can't find it during the hysteroscopy and will not cause infertility. I have sharp pain in my abdomen during ovulation until my period, and doctors suggest to take aspirin. Recently, my IVF doctor postponed my treatment after looking at the scanned copies of my uterus. I would be so grateful if you could advise me. What is this mess? Mass. That was a typo. I didn't say mess. It says mess here, but I know she meant mess. And whether to remove this shadowing solid object and or if there's a risk to do so. My worry is something is left in the uterus after miscarriage. The CT scan reports uterine calcifications. Thank you, doctor. So Jen, your question's really good. And I would say that it is very possible that it's actually not in the lining of the uterus and it could be within the wall. Aside from placental tissue or placental calcifications, these little tiny solid objects, which are calcifications, could also represent old fibroids. I've seen them before. I've transferred for patients who have them, and sometimes they could still be from placental tissue, but if they're within the wall in a way that they're not affecting the ability of an embryo to implant, I'm not going to worry about it. If I can't see it with my eyes on hysteroscopy, then I know that it's in a place where I don't have to worry about it. And sometimes I can, see it inside. It's as if it's inside the cavity, and I do a saline sonogram, and it's clearly outside the cavity and not going to get in my way. So if you still think that there's something going on and you want a second opinion, the easiest thing to do is maybe have someone else do a saline sonogram for you. That's what I would consider, so that you don't have to worry if something is left in your uterus after a miscarriage. One thing to pay attention to is your menstrual flow. So if your menstrual flow hasn't changed at all, then that's probably a good sign that probably everything is just fine. This next question comes from Jennifer. She's 42 from Georgia. Dear Dr. Amy, I'm 41 and 7 months old. I have a 12-year-old healthy boy born naturally. My overall health, no problems. My spouse's sperm analysis is good, AMH 2.76. I just did my first IVF cycle in March. Unfortunately, it did not work. All of my screening test results before IVF are good. My IVF doctor has no concerns about me. Retrieved 9 eggs, created 5 embryos. 4 embryos reached to day 5 in grade AA. 1 embryo reached day 6 and is grade AB. However, the PGTA testing shows that all 5 are chromosomally abnormal and cannot be transferred. I need to add that the DNA genetic testing that I performed before IVF showed that both of us are normal. Can you please kindly let me know how to reduce this risk in my next round to increase the successful rate? And how soon should I start to try? Which steps in the process could go wrong? Should I do PGTA testing again at my next IVF round? Jennifer, these are all great questions and you're doing all the right things. And if anyone has a chance to have a healthy pregnancy at the age of 42, it's definitely someone with numbers like you. The good news is you make mature eggs. You had 9 eggs retrieved. You make beautiful blastocysts. The fact that they're not normal is just a function of your age and nothing more. And that's so hard. Unlike for someone who's, let's say, 22 years old, you would expect that, you should always get normal embryos each batch. At 42, no matter how many eggs we retrieve and how many cycles we do, we may still not be able to get a single normal blast. Each blastocyst at the age of 42 has about an 85% chance of being genetically abnormal. And it's not one of those things, if you get 10 eggs, 1 out of 10 will be normal. It's still possible that 10 out of 10 could be abnormal. And that's not being negative. That's me being realistic and practical. So I would say you have to be open to doing many cycles. It might not be until your 4th, 5th, or 6th cycle that you could see the normal embryo, but I'm one of those people that's extremely, I don't exude, I hope, toxic positivity. Maybe a little annoying positivity, because my sister's like, I swear to God, if you say sparkle one more time, I'm going to throw up all over you. But that's okay. I can handle that. So I'm going to throw in some sparkle right here. Jennifer, I want your embryos to sparkle, not just on the outside, but on the inside. They're definitely sparkling on the outside by how beautiful they are. But in terms of what I would suggest that you could do to make them sparkle on the inside and get your genetic viability hopefully normal, and again, not in our control, but still there are things that I do differently than maybe others, is maybe include HGH, consider NAD as a supplement. If you aren't taking CoQ10 already, definitely add that. I do think that doing PGTA testing is helpful, because I don't want you to waste your time transferring an embryo that could result in a miscarriage. However, I do think it's important to make sure that your fertility clinic is making sure that they are sharing with you their protocol and policy for transferring mosaic embryos and reporting mosaic embryos, because it's possible that you might have 1 or 2 low mosaic embryos that you're just assuming are abnormal, and you could transfer those and they can result in a healthy live birth. So my bias is for PGTA testing in people who have beautiful, gorgeous, high-quality embryos. However, if your doctor thinks that you should probably skip it, I would definitely listen to them and ask them why or why not. But I hope these little suggestions are going to be helpful. This next question comes from Jackie. Jackie is 32 years old in Bakersfield. I don't know why I was saying Pennsylvania. Sorry, Jackie. It clearly still says Bakersfield. I know that Bakersfield is not in Pennsylvania. I'm 32, and I've been trying for 3.5 years now. My husband feels he occasionally may have retrograde ejaculation for the last year now. Does that go away on its own, or what can we do about it? Would love to know your insight on how this can affect IVF. I haven't started yet, and what we can do about it. Thank you so much. So the question is, why is your husband having retrograde ejaculation? Does he have untreated diabetes, or is it uncontrolled diabetes, and can we get better control? There's certainly things that you can do with retrograde ejaculation to get it from the urine after ejaculation, and you can still do IUIs. However, that might feel like a lot of work, and you might not want to do so much work to get pregnant. You might want to just get the sperm, make embryos, so that for baby number 2, you don't have to worry about it, and you can have your embryos on ice for your future babies. So I think the best thing to do is to meet with a fertility urologist, also known as a male fertility specialist, who is a urologist who went to baby making school, just like OBGYNs. You would think that OBGYNs, part of the training is baby making school, but they get very little baby making school. They get more baby delivering school, and then we do the baby making school 3 years of training after 4 years of fellowship, of OBGYN training. And you're like, what? 7 years to figure out that an egg and a sperm make an embryo? And the answer is yes. And I would do it all over again. So I hope that helped, Jackie. This next question comes from Renata, age 35 from Europe. Dr. Amy, can I be a candidate for IVF? My AMH is 0.16, FSH is 13.8, estrogen level is 82. Thank you. So the answer is, Renata, absolutely yes. I would be as aggressive as you feel comfortable being and freeze enough embryos for your future family. At 35 with an AMH of 0.16, I've had patients who, very recently, I'll share a story with you, 4 eggs, all 4 mature, 3 fertilized, all 3 beautiful blastocysts. So you just never know what you're going to get until you try, but I think it's really important for you to be open to all possibilities, that you might not get enough viable eggs in your first round. It might take several, and the other possibility is that there might be some diagnostic testing that would help your doctor guide you better. So the question is, why at 35 is your AMH 0.1? Is it just basically age-related? You weren't born with as many eggs. It might be genetic. Your mom might have had the same thing. But is there something more to it? Do you have an abnormal chromosome analysis, and do you carry fragile eggs? So those are 2 important tests that I would have you consider doing before your IVF journey, so that you're not given a surprise. There's certain surprises I like Amy, I'm pregnant and I didn't need your help. And I'm like, oh my God, that is so awesome. Thank you. The surprises of, Amy, I did IVF and then I found out this or that about myself, like those are the kinds of things that I'd rather not find out after going through IVF. This next question comes from Lisa. She's 38 in Florida, and here's what she says. I am currently trying to conceive and taking a prenatal vitamin that includes choline. I've listened to your show and you often recommend CoQ10. Would it be beneficial for me to add CoQ10? Is it safe to take with prenatal vitamins? And I feel like I should probably have a tattoo that says here, take CoQ10 until you're done having babies. Or I should put it on my nose. It probably will all fit on my nose. I have a very big nose. I should just put CoQ10 around there. So the answer is yes. I have all my patients. I see lots of women in their 20s and early 30s who come to me talking about egg freezing, and I'm like, take CoQ10 until you're done having your babies. And they're like, what? And I'm like, yes. I don't want patients to take CoQ10 when they're struggling to conceive. I want it to be part of our, daily routine, early on. And that's just my bias, and I feel like it's going to help. And in 20 years, all of y'all who've been listening to the Egg Whisperer show are going to reach out and you're going to be like, Amy, you were right. I started taking CoQ10 in my 20s, and I didn't have as hard of a time as I thought I would when I was 37. I mean, I don't know how you would know that, but I'm just really hoping that it'll help people out there. This next question comes from Carla, age 39 from California. Should I be worried about the COVID vaccine affecting my fertility? And Carla, the answer is yes. It is a very good thing to be thinking about because, of course, who would want to do something that affects their fertility? But you shouldn't be worried that it's going to affect your fertility. I have had the COVID vaccine along with hundreds of my patients. I have a patient population that's probably 90% vaccinated now. And I would say that the fertility rates or pregnancy rates in my clinic have not gone down, and my patients' fertility levels have not changed for the worse. So I think since December, having the number of patients that I've had vaccinated, and also with all the scientific studies that have shown that it does not worsen or affect fertility, I can very comfortably and confidently tell my patients that you should get vaccinated. And I want all patients to be fully vaccinated before pregnancy. So that means you should be done with your vaccines 2 weeks before your transfer or 2 weeks before your IUI, if possible. Okay. This next question comes from Phoenix, age 40, who lives in California. Hi, Dr. Amy. Thank you for all your good work. I'm 40 and I've had an unsuccessful IVF cycle in February with a clinic that I was happy with, but turns out they don't have the best SART results for my demographics. I have DOR, high FSH 15, my AMH is 1.3, and I did an antagonist protocol with 5 days of Clomid, 300 of Gonal F, 2 vials of Menopur, and a 5,000 pregnal trigger. I had 13 eggs retrieved, but 7 were mature, 3 fertilized. In spite of using Pixie, we got 2 embryos, but not a good one. My partner has 1% morphology and had 15% motility numbers on his sample. During semen analysis, his morphology was 1%, but other numbers, including fragmentation, were okay. Both of us are on vitamins, CoQ10. We have 1 more IVF cycle we can do before we need to consider other options. Which protocol would you recommend? Which Bay Area IVF practices would you recommend for me? CCRM, spring, RSC. Sadly, I can't come to you due to insurance. So here's the deal, Phoenix. You can't go wrong with any of the clinics in the Bay Area. We are so lucky that we have access to some of the best IVF centers in the world just here down the street. I'm so lucky too, but I'm friends with everybody. And what I mean by that is I can, let's say, do a case at a certain lab because I don't own a lab right now. So I went into my drawer, not my drawers, but I went into my desk drawer to pull something out. This is called a Zymot fertility chip. I mention things on the show, not because I'm paid by anyone, although they should pay me, don't you think? I mean, the CoQ10 guys, I have it tattooed on my nose. But Zymot fertility, I think, is something that could potentially help you. If your partner has not seen a urologist, I think I should rename male fertility specialists, those urologists, urologists. You heard it here first, people. But I would talk to your husband about seeing a male fertility specialist, getting a varicocele check, even though his DNA frag is good. We want to see what we can do to make his sperm even more sparklier. We want it to be the sparkliest on the day of the egg retrieval. So one way we can do that is make sure his testosterone level is normal. Not normal for an 85-year-old man. We want normal for someone who's his age. And the way to do that is get his testosterone checked, get it evaluated, and see where he's at. And there's certain drugs that I sometimes recommend to my guys, but I have the urologist do it. There's no such thing as a urologist, you guys. But they usually recommend Clomid, Arimidex. There are other drugs like HCG and Gonal F, for example, that guys can take that can increase their testosterone by increasing sperm counts. It's a win-win for those sperm cells. And by having better quality sperm, better morphology, that might put your embryos in a better situation. And you could potentially see a better fertilization and a better blast formation rate as well. While Pixie can be helpful, I think sometimes in some cases this little chip could be a little bit more helpful too. So spring, RSC, CCRM, I don't think you can go wrong with any of them. I think that all the doctors at all the practices are fantastic. As far as protocol to recommend, you have 13 eggs. I would say do what you can to get all 13 to grow. I personally don't like Clomid. I know you guys hear me saying that a lot. I like Femera in my protocols, and I like how you use 300 of Gonal and 150 of Menopur, but I would potentially switch it and use 150 of Gonal and 300 of Menopur, and rather than Clomid, perhaps use Femera. Consider increasing your trigger shot to 10,000 units, and perhaps consider pushing your eggs out one more day or your follicles out one more day if your doctor thinks that that would give you more mature eggs. This next question comes from Lori, age 48, in Cincinnati, Ohio. I'm looking for a clinic to try IVF using my own eggs first. Do you have anyone you would trust in this area? I need a fertility doctor who is as positive as you are, or shall I just head to your office? Lori, I have to tell you, it's going to be really hard to find anyone who's as positive as I am. Literally. For a 48-year-old woman, I'm like, come on down. Let's see what I can do. I have someone pregnant right now. I'm not going to say how old she is, but she's older than 46. And I cannot wait to find out if the pregnancy is normal or not. And I cannot wait to hopefully have a 48-year-old pregnant too one day. She's not quite 48, but one day I'm going to have someone 48 with a pregnancy that's healthy with her own eggs. That's just something that I'm hoping that I can do. I got some tricks up my sleeve, and I know that there are other doctors out there that do too, but some of the things that I do aside from supplements is, first of all, making sure that you're a good candidate. So you have to have eggs that grow in order to go through IVF. If you don't have an egg count that, let's say, is more than one, then it's usually really hard to get to an egg retrieval and retrieve an egg. But there are doctors out there just like me, I promise you, that would be excited to see you. So for example, Dr. Murphy in New York, that might be closer to you in Ohio, and he is doing his clinic, I think is Ovarian Rejuvenation Clinic, and he's doing PRP injections in ovaries. So he's doing some pretty cool stuff. So I would head on over there unless you want to come here. And of course, I'll see what I can do to help you. This next question comes from Natalie, age 35 in Texas. Hi, Dr. Amy, I'm 35. I had my first egg retrieval and I got 5-day embryos, 4 good grade, 1 fair, not tested. Could not do a fresh transfer because my elevated estrogen and progesterone told my doctor that I should probably not do that. I requested a saline fusion sonogram before frozen transfer and to do a round of antibiotics due to a previous hysteroscopy and found a septum, polyps, endometriosis, and endometritis. My saline sonogram was normal and I've completed 2 weeks of antibiotics before starting baseline this week. Have I done enough to get into a transfer? My fertility doctor does not think that I need to do an ERA, and we haven't had any failed implantation with IVF. I had 1 normal full-term pregnancy 10 years ago, 2 failed IUIs, and I'm worried my uterus or lining will not be healthy enough. Taking all the IVF lining foods, drinks, supplements that are popular and recommended. You're amazing, and thank you for being there for so many of us during our journey to baby. Okay, Natalie, here's the thing. You have 4 good grade embryos. What we don't know is this. Are they PGS tested or not? Yes or no? How many actually have normal chromosomes? What I don't want you to do is go through a transfer and transfer your best embryo and then do an ERA test and realize that, darn it, I probably should have done that. So my gut instinct is do the ERA test. You had a hysteroscopy a year ago. I would want to make sure, even though your SIS was normal, maybe consider 1 more SIS. I don't know that you need to actually. I'm going to take that back. I think your doctor's being pretty complete to make sure that the septum is completely resected and there's no scar tissue. But I do think perhaps that an ERA test, if you haven't done genetic testing and don't know exactly how many normal embryos you have, makes sense to me. It seems like somehow they diagnosed you with endometriosis. So I just don't know, based on what you've shared, if you've treated it enough. So my vote is, here we go. I got there, you guys. Finally, and I got there. I would do implantation testing with an ERA and Receptiva DX test. I would take a look at the results and then decide if you needed to do more treatment before you transferred. My concern is with endometriosis, you might need a slightly different protocol than what your doctor is going to use for you. However, you could transfer your first embryo and see what happens, but I think transferring an embryo and have it not work really, really sucks, obviously. So if you feel up to doing implantation testing, just suggest it to your doctor and see what they say. This next question comes from Lolly, age 39, in Canada. Hi, Dr. Amy. I'm so grateful for your show. I just had my 2nd egg retrieval, and out of 13 follicles, 4 eggs were retrieved and only 1 was viable. The lab said the other 3 eggs looked granular and slimy. Okay, that's really means slimy. Really, couldn't they find a better word? Slimy, though? Slimy. Oh, God, I'm sorry. I think they meant, I don't know what, slimy? I'm sorry, that's just slimy. Okay, I stemmed on 300 of Gonal, 75 of Menopur, 100 of Clomid, low dose HGH for 3 days of stem. I triggered with 5,000 of HCG, 0.8 milliliters of Lupron with a retrieval 36 hours later. 4 months ago, I had 10 eggs retrieved from 11 follicles, 9 mature after stemming on the antagonist protocol, no HGH. My AMH is a little bit lower, FSH is 11, but I'm told these are in normal ranges for my age at 39. What do you think caused all the empty follicles during this last round? And would you recommend trying again? And if so, would you recommend what do you recommend we do differently for your protocol? Would you recommend taking HGH for a longer period prior to stem? I'm already on ubiquinol, NEC, prenatal, and I just started ASI. So I would also add NAD. If you aren't on it already, you should be able to get it without any problem. The company that most of my patients use is True Niagen. So you can go to trueniagen.com, get the 150 milligram dose and start it first thing in the morning. If you can tolerate it well, then go up to 2 tablets per morning and then stick to 300. This is why I talk so fast, and this is why I'm actually 75 years old, but I look 45. I'm not 75. However, gosh, who was it? Naomi Campbell. I don't know if you guys saw today. It was all over the news, at least my news feed, that she just had a baby. And I was like, that's pretty darn awesome. Anyways, I think it opens up the hearts and minds of people who have always wanted babies reading her story, and I just thought that was incredibly special. Lolly, nothing to do with your story. I'm sorry, I just threw that in there, but I just felt like saying that because of the NAD comment that I made as a suggestion for you. So here is what I'm thinking. What I'm thinking is this. 4 months ago, you had a cycle that basically resulted in 9 eggs mature. Compare both cycles. Remember my sparkle checklist. Look at the size of the follicles on the day they trigger you. Okay? How big were they 4 months ago versus now? Also look at the time of the trigger shot 4 months ago versus now. Was there any difference? Same with your estrogen level. Look at that. You're going to be like, yeah, I know, Amy, 4 months ago versus now. I get you. But there's a reason why these cycles are not failures. They're learning experiences that can inform us, and they tell me what to do next. I hate the word failure. I like the word learning experience, because I feel like when we say IVF failure, we internalize that and it makes us feel like we did something wrong. And obviously we have no control over these outcomes. The only thing that we can control is our understanding as to what has happened and why, and then obviously what we can do differently as human beings to give ourselves the best chance of pregnancy. I would suggest flipping your Gonal F to Menopur ratio. I like more Menopur to Gonal F. That's something that might help result in more mature eggs in some people. The other thing that you might want to consider doing, I'm not sure what the time lapse is between the 2 different cycles that you did, but one thing that I've had really good success with is doing mid-luteal phase starts. And I know they do that in Canada as well. So I would definitely talk to your doctor and see if they would be open to trying that as a different approach to helping you get as many eggs as possible that are mature and as many blastocysts as possible. So when it comes to getting empty eggs, or I should say empty follicles, the way I think about the eggs were there, they were just too immature to float to the middle of the follicle for your doctor to retrieve, or you ovulated on your doctor, and I imagine if you did, they would be more transparent about it. Or the other possibility is that there was something with the trigger shot timing, and that's why things didn't go as planned. But overall, I still think that you're in good position to get more healthy embryos. I don't know that that's a word, more healthy embryos in your next cycle, but see if your doctor would consider some of these things that I suggested. And I think that's pretty cool, because it's not pretty cool. I think your doctor is pretty cool. You're pretty cool too. But I think your doctor is pretty cool because I have not had much luck having patients who've reached out to me for a second, third opinion consult from Canada, finding a doctor who will give them HGH. So I think that's pretty special that your doctor is willing to be creative like that and help you in that way. This next question comes from Jennifer, age 36 in New York. Hi, Dr. Amy. Thank you for all you're doing. Your hopeful outlook on fertility issues. I'm 36, soon to be 37. I'll be trying to conceive after my wedding in 4 months. I had my levels checked at 35, my AMH 5.3, FSH 1.4, but not day 3. I've been told that my fertility looks good, which I think was by interpretation of my numbers. However, I'm worried about my fiance. Ever since my fiance and I have been intimate, I noticed that he ejaculates a very small amount of semen. The semen texture also seems too watery. Every so often he appears to have more normal ejaculation, but it's not frequent. I have a strong feeling that it could be related to his medication. He has ulcerative colitis and he's taking a couple of medications. I've also read studies that show that these medications reduce semen volume and other sperm parameters. What's your experience with these drugs and male fertility? And the answer is, Jennifer, I think you could be onto something. My job is not rocket science. You just notice patterns, and then you can just see what's going on by doing a simple test, and that's a semen analysis. So let's get that done. I would say 4 out of 5 fertility doctors have checked their partner's sperm. That one that hasn't, the 1 out of 5, didn't, because they're in a same-sex relationship with another woman, assuming that we're talking about only female fertility doctors. So you see what I'm saying? Test, don't guess. Get the sperm checked before, it doesn't have to be like a requirement before you guys get married, but I think it makes sense as part of your fertility planning. You've had your fertility levels checked. You could literally buy a microscope off Amazon, probably for the same price as a semen analysis, and do the same thing at home. That wouldn't be weird in my world, but in most people's world, that might be odd. In the future, however, I see a world where people will just be doing that. But until then, you can do the Yo sperm kit, literally YO, really cool little thing that you can get, attach it to your phone, put a little drop of sperm in the little thing that they give you, follow the instructions, and voila, you see sperm porn. Yes, lots of sparkling swimmers across your phone as a video. And then you can also send it to your friends and family. I'm kidding, don't do that. But you can send it to your fertility doctor and see what they think. Alternatively, there is the Meet Fellow kit. So that's a really cool do-it-yourself. They send you a cup, you ship it back, they send you a report within about 2 business days. And they also have a new add-on where you can also freeze sperm as well. So that's my thought. And I would say it's a very good thought that I just had for you, to have the sperm frozen and have his sperm analyzed, and then given your young age, 36 soon to be 37, one of my Egg Whisperer Golden Rules, number 3,954, is if you're 37 years old and you want at least 1 kid, go straight to IVF, especially if you want 2. Because if you want 2 kids and you're thinking about how old you're going to be with your second baby, you can imagine it might be harder to get pregnant at that age. So I'm being extremely hopeful, just being realistic and throwing out the numbers that I think could be true in your case. And it sounds like you'll have a great chance of pregnancy based on your AMH. However, your husband or husband-to-be sperm, you might be onto something. This next question comes from Sam, age 26 in California. Hi, Dr. Amy. My husband and I are both 26, and I have a high AMH 17 and no other issues. My husband has low sperm motility, morphology, and count. We did IVF with ICSI, 33 retrieved, 21 mature, 16 fertilized, 0 day 5 blasts. I just said that. That hurts to even say that. However, you guys, we turned the corner here. We ended up having 4 day 6 embryos, 2 6BBs, and 2 5B minuses. Not the best grades. The embryologist said poor embryo quality is usually due to poor egg quality. Boo, I hate that. I never blame women for everything. How can I have poor egg quality at 26 years old with an AMH of 17? I was on CoQ10 prenatals, fish oil, vitamin D for 3 months leading up to IVF. What else can I do? Was it just a bad cycle or bad luck? But 16 fertilized to 0 day 5 is a big drop. Is it sperm quality? The embryologist said they found more than enough good sperm to do ICSI, and I've heard you talk about sperm DNA fragmentation testing, but my question is this: if the results come back high, what can we do? Sorry, there are so many questions embedded in there. Thank you for your help. Okay, Sam, here's the deal. So our issue is an embryo quality issue at 26. The question is it genetic? How do we know? We don't. You haven't done genetic testing of your embryo, so we don't really know if there's any type of pattern here. So that's what I would suggest, number 1. I would do carrier screening if you haven't already, and I would do a chromosome analysis too on both of you. These tests are easy to do. They're a heck of a lot cheaper than going through IVF that doesn't work. A chromosome analysis you can usually do for between $350 to $450. I order it through Invitae or Quest Diagnostics, just depends on where the patient lives. If she's going to be coming into me, then I'll draw her here and send it to Invitae. Otherwise, if they live out of town, then I'll send it to Quest Diagnostics. Alternatively, I do think that doing a sperm DNA fragmentation test makes perfect sense. The other thing that I would ask your doctor to consider doing is consider doing a lower stim protocol to maybe get less mature eggs. Maybe 12 to 15 would be better for you. The sperm DNA fragmentation test, regardless of the results, I would still add something special to make the sperm extra sparkly. And what I mean by that, not to sound super cheesy, see, that's the thing, I see hearts. If I say sparkles, you got to hit the hearts there for me. Maybe adding Pixie or Zymont. But if you were to do another cycle, I would say it might make sense to go lower stim, add HGH, make sure you've done the genetic testing up front, and then really ask your doctor, what is my DNA, oh my goodness, what is my diagnosis? Why did we do IVF in the first place, right? Diagnosis before treatment, then you design your IVF cycle based on what? Your diagnosis. So you went into the IVF cycle saying low motility, sperm issue. So let's get back to basics and go through Ball's method, right? So figure out, why is the sperm motility low? Is it genetic? Is there a varicocele, right? And the things that you can do, I've already mentioned it. You can use Pixie. You can increase the sperm or decrease the sperm DNA if, let's say, the testosterone is low, by other medications like Clomid and Arimidex, Gonal F, HCG shots that we give to guys. Remove a varicocele if he has one. I always want to do what I can do to help people get pregnant without my help, even if they need my help, so that when we do the IVF cycle, it's hopefully one and done. I know that a lot of times it might take more than one cycle, but I like the idea of imagining that I'm going to do this once, so I'm going to make sure that I've done all the tests up front before I put an embryo in. And let me tell you, when I'm holding a patient's embryo in my hands and I'm putting that embryo in their uterus, you can imagine that I've gone to sleep the night before making sure that I haven't missed anything. big picture, because that's really important to me. At the end of the day, we're dealing with human biology and we can't control it. But I just know we can control the decisions we make before we go into an IVF cycle. So you're asking all the right questions, and I'm glad there's so many. And you should go to your doctor, go through Tushy Method, Balls Method, but I think ballsmethod.com is probably the best checklist for you to go through. Talk to a male fertility specialist and have them rule out a varicocele, low testosterone, sperm DNA fragmentation abnormality, and a varicocele. And I think I said that like 10 times, but I'll say it again, varicocele. So this next question comes from Charlotte. Charlotte is 40 years old from San Antonio, Texas. Hi, Dr. Amy. My AMH is 0.65. My follicle count varies from 4 to 9. I did timed intercourse with letrozole, 5 milligrams in Follistim, 150, and I produced 2 mature eggs, but it wasn't successful. I started IVF with estrogen priming pills after ovulation at cycle day 1, then birth control pills for 6 days before starting stims. Baseline follicle count was 4, estrogen less than 5, lining was at 7. Protocol was birth control pills, letrozole, microdose Lupron, Follistim, Menopur. On day 7, I had my first progress scan, and here are the results. No change in the estrogen levels, and out of the 4 follicles initially visible, 1 was visible at 7 millimeters. So before I keep going, Charlotte, here's the deal. When you take Femera, you actually don't expect to see any change in the estrogen level. Letrozole makes your estrogen level basically undetectable, and that's how it works, and that's okay. It doesn't mean that it's taking your estrogen away, your eggs away, or anything like that, making you go into menopause sooner or causing you to have more fertility problems than you already do. But I wouldn't worry about your estradiol level at all when you're taking Femera in your cycle, which is what you were doing. And here's what you're going to share next with us. I'm going to read more. We then did another 5 days of stim before canceling the cycle. I have 2 kiddos, 17 years old and 2.5 years old, conceived naturally, no issues, and 2 miscarriages in 2019 and 2020. I had a blighted ovum and a slow fetal heart rate that stopped at 7 weeks. I started heavy bleeding again after day 2 of stims, and I'm still going. What protocol do you recommend? So here's the deal, Charlotte. I know what everyone else is going to say. No birth control pills. That's what I'm going to say. I think you are way too suppressed based on what you've described to me. Your AMH is 0.65, so I would expect exactly what your follicle count suggests, between 4 and 9 eggs. So I would say hold off on the birth control pills. I would say the estrogen priming might be too suppressive for you too. Same with the Lupron. I think all of that together, your ovaries were saying, leave me the heck, and might have used an expletive alone. And now you're going to listen and you're going to say, heck with all that. And you're going to say, I'm going to go natural cycle. I'm going to go with my original wave of eggs. And then I'm going to go with the flow if it's a really good antral follicle count. And if you don't like the follicle count, you're going to wait until ovulation and maybe start mid-luteal and see what you get from there. But that's my recommendation and what I would do in a case like yours. And of course, add CoQ10, NAD, prenatal vitamin, vitamin D, and fish oil if you aren't already on them. This next question comes from Monique, age 40, from Turkey. Hi, Dr. Amy. Thanks for sharing your wisdom with the fertility challenged women of the world. I like that, fertility challenged. Better than infertile. I don't like that word. I'm changing to a new doctor after 2 less than wonderful cycles, and he recommended I do egg pooling. Diagnosis is DOR with no genetically normal eggs retrieved. I didn't know what pooling was, and I thought I'd explored every avenue of IVF. My question is, what is egg pooling? And do you recommend we try it? Can it be done with genetically tested embryos? So Monique, here's the deal. Egg pooling basically means you're doing cycles and freezing eggs. That's what it means to me. Another way of thinking about it is egg banking, but I would say do embryo banking. I think it's way more efficient, and the reason is if you freeze an egg, especially if it's lower quality, and it's normal to have lower quality eggs at 40, the survivability once you thaw them is lower, and then once you inject them, the likelihood of them turning into a healthy embryo is lower too as a frozen egg rather than fresh. So my recommendation is to do embryo banking. I like the concept. I like what your doctor's thinking. Let's be open to many cycles. I would say definitely do that, but think of it as embryos and not eggs. And I would be prepared for everything. So in a case like yours, I would be prepared for even doing a fresh transfer as you're going, because you just don't know what the embryo viability is going to be. So if you have an embryo that looks like it might not benefit from being frozen because the quality is poor, but it's still alive and would have a benefit of being transferred, then I would say start hormones after your egg retrieval so you can have all options open to you. I have a patient, she has a baby, not so much a baby anymore. She's now 7 years old, and we still call her 1%. Not to her face, though. I'll never remember that. I'll never forget that day where I said the likelihood it's still alive, it's a 1% that this embryo could turn into a healthy pregnancy. I did say that, 1%. And the name just stuck behind her back, though. She's brilliant and gorgeous and amazing now. This next question comes from Rachel, age 38, from Australia. Hi, Dr. Amy. I love your show. I'm always recommending it to others. I'm doing IVF using donor sperm to become a solo mom. So my next way of changing the language that we use about solo motherhood. I learned it from a patient. She gave me permission to share it with you, was independent mother. I love that. I'm an independent mother. Solo mom, I don't like the idea of being solo because solo sounds like you're alone and you're never alone, right? I mean, the UFO stories that we're hearing nowadays, we truly are never alone. But independent, there's just something about that that sounds just glorious and strong, and I just like it a lot more than solo. So I'm going to replace it with an independent mom. My AMH is good. My first IVF cycle, here's what happened. I had Gonal F of 187.5, trigger shot of Avidril 12 follicles, and on the trigger shot day, my lead follicle is 22 millimeters, and I'm not sure what this says, so I'm going to skip to the next sentence. I went straight into a second cycle. It seemed that first cycle didn't work out, and I'm not sure exactly why, but that's okay. I went straight into my second cycle on the next menstrual cycle on the same dose. 9 eggs were retrieved, 6 fertilized, 1 good 5-day blast, 4 BB. The other embryos were 2 poor quality on day 6. My embryo implanted, but unfortunately this ended in a chemical pregnancy this week. This is week 5. I do suffer from IBS and no other known conditions. What can I do to improve my chances? Okay, so here we go. You can still take NAD, CoQ10, and I know you're probably already taking a prenatal. Look at your diet and making sure you're eating healthy, sleeping well, decreasing stress. Find your fertility team, because there's no better time than now to find that team. Therapist, exercise, acupuncture, mindfulness, and meditation. Create your own home, of course, mind-body center, because there aren't that many mind-body centers open right now around the world, but I would do that. Look at the sperm quality. Even though you use donor sperm, reach out to the sperm bank and be like, can you tell me how many live births this donor has had, and see about switching to a different sperm donor. Ask your doctor what your FSH estradiol levels were at the start of the cycle. If they haven't tested that, perhaps ask them to test that. I love the fact that you got a good day 5 blastocyst 4 BB. I love the fact that you had 9 eggs retrieved. I feel really good about your chances. I would say be open to doing at least 2 more IVF cycles, and hopefully you will be successful. But go through my Angel Method, that checklist that I have there, angelmethod.com, and go through everything and ask your doctor, have you done this? Have you done this? Have you done this? Have you done that? Have you ruled this out? Have you ruled that out? And I know that sometimes doctors say, well, usually you have to have 2 miscarriages in order for us to do these kinds of tests. But we're talking about a pregnancy. I'm not going to wait until the second one. And I find that to be incredibly cruel to tell people. And I know people use those words, and those just aren't words that I use. And so I'm hoping that by you guys watching this, you'll be able to advocate for yourselves and say, you know what, I'm kind of working really hard here to go through this IVF stuff. And so I'd really like to be given the highest chance of having a healthy pregnancy. So could you please just do me a favor and make sure you ruled out, retained pregnancy tissue, adenomyosis, the scar tissue, uterine septum, antiphospholipid antibody syndrome, factor V Leiden. Can you just do me a favor and just humor me and just rule this stuff out? I would say that 8 out of 10 fertility doctors would be like, heck yeah, Rachel, I'm going to do that. Don't even worry about it. And in fact, I was already thinking about doing that for you without you even saying it. So if you haven't had your post-miscarriage consult, I would schedule that now and go through all the things that I just brought up. And hopefully they'll agree too. This next question comes from Caitlin, age 31 in California. How long should you wait after your COVID vaccine is completed to transfer an embryo? Easy, 2 weeks. And the reason, I want you to be fully vaccinated before you're pregnant. So that's why I recommend 2 weeks from vaccine to transfer. I think that's a good recommendation, but I'm kind of biased. This next question comes from Mary, age 33 in Texas. Hi, Dr. Amy. I just recently went through an IVF cycle, and out of the 4 that made it to the blastocyst stage, 1 came out PGTA normal. I'm 33 years old and trying for our first. You suggested I do another round, or should I go ahead with the only embryo we have? We only want 2 kids. Mary, yes, I would do that second round now. There's no better time than now. And I would go through my embryo diamond checklist. Go through it all, talk to your doctor, have them talk to you about the genetic testing report, and make sure they're reporting to you. Make sure which embryo is mosaic, and make sure that they've actually given you that information and disclosed it, because some of your low mosaics could actually be normal in the end and not abnormal the way it says on the piece of paper. And I don't want you to be throwing away any embryos that could potentially help you. So yes, I would do another cycle now and take CoQ10 if you aren't already. This last question that you guys sent in for today's Ask the Egg Whisperer comes from Veronica, age 36 from Las Vegas, Nevada. Can you make a video on at-home ICI timing? I should. I've had 4 failed attempts, but I was using a lot of pre-seed. Recently saw your video, so I omitted the pre-seed from my latest and 5th attempt, of which I am now 5 days post-ovulation. My LH surge takes 15 hours with the highest peak at 12 hours. When using frozen sperm, how do I time it when to insert with a soft disc? When I read online that sperm capacitation can take 8+ hours, the donor genetic carrier screening is perfect. My cycles average 28 days with no bothersome menstrual cramps, 3 days of flow. Current supplements are CoQ10, resveratrol, Vitex, prenatal, omega-3, alanine, maca with mucinex during my fertile window. Hormones will be checked on day 3 if this attempt was unsuccessful. About 5 years ago, I had a pelvic ultrasound that was clear. I don't have insurance to cover costs, so what are my next steps? Veronica, the first thing I would do is check an AMH, can't hurt, and an HSG. I think both of these things will be extremely cost effective for you. Not sure how many kids you want, but if it's only one, perhaps just do you could still do both actually. But I think looking at your tubes and making sure they're normal before you do another IUI makes perfect sense to me. And for any patients who are over the age of 30, fertility pills are super cheap. Super cheap, maybe $1 a pill for a generic Femera or Clomid. And I recommend trying to help you ovulate 2 eggs to give you a higher chance of having 1 healthy pregnancy. The reason is that when we're over 30, when we ovulate an egg, the egg isn't, I'd like to think that every egg is going to be genetically normal, but the reality is that it's not. And the other thing is that frozen sperm, if that's what you're using, isn't going to be as viable. So the more eggs you ovulate, the higher the chance that you're going to have 1 fertilized. So that's why I would recommend trying to get you to ovulate more than 1 egg. So you can do that by taking fertility pills, cycle days 3 through 7, start monitoring ovulation, cycle day number 10, and then do, let's say, leading up to your LH surge, maybe 1 IUI the day before, 1 IUI the day of the surge, and then 1 IUI 2 days later. Because I can tell you those surges are those LH tests are quite inaccurate. And they can make you feel that you're going to ovulate when you might have already ovulated. They make you feel that you've already ovulated when you haven't yet. So that's why hopefully these suggestions that I'm making are going to be helpful. The soft disc, I'm not too impressed by the results of the soft disc, honestly. I don't necessarily feel like it's going to be that huge of a help. And they can kind of be somewhat messy for some people. However, if you're using it and you're not having any problems using it, then that's okay too. Okay, you guys, thank you for joining me on today's Ask the Egg Whisper. What I'm going to do right now is I'm going to scroll through your live chatted questions. There are a whole bunch tonight, so just bear with me as I start from the top and then I'm going to go down. And we'll see here. Lots of hellos, which is very sweet. Hi, hellos. So I'll eventually get to a question. I promise you. Here we go. I had a miscarriage at week 8. All tests were normal. Grade A genetically normal embryo. They checked my NK cells. They were slightly high. So in my next embryo transfer, I was put on 20 milligrams of prednisone. Implantation did not happen. Do you think it was because of the prednisone? Do you recommend we do anything else we can do for success? Full embryo transfer. So one of the things I would wonder is, what was the quality of the embryo that you had? Embryo quality has a lot to do with the implantation rate. Sometimes an embryo can be lower quality and genetically normal and not implant because the cells just weren't strong enough to implant. The other thing to consider, if you can do implantation testing, talk to your doctor about doing the ERA cycle, ERA testing, and doing the receptiva DX test. Rule out a uterine septum or any abnormality like a uterine polyp before you transfer. So if you haven't done a saline sonogram, for example, in the last 6 months to a year, this would be a great time to do it. Next question is, 12 days post 5-day transfer, my HCG was 824. Then it went up 2 days later, actually 3 days later, to 1503. And then at 16 days, then 2 days later, it was 2971. Are these numbers concerning since they aren't doubling? The answer is no. Your numbers are rising really nicely. They are approximately doubling, and that's usually enough. So your numbers actually seem really reassuring to me. And I would have you go in for an early ultrasound. So if you were my patient, I would bring you in for an early ultrasound at approximately 6 weeks of pregnancy or sooner if you're worried. If you have a history of miscarriage, I usually bring my patients in even sooner, around 5.5 weeks. Even though we know we're not going to see a heartbeat, I can tell you there's something that's really satisfying about seeing a nice, beautiful sac with a nice little yolk sac right inside your uterus. Then I bring you back the next week to see that diamond on the diamond ring. That's sparkling, and that's what we call the heartbeat. Next question, triggering tonight for a Friday retrieval. Follicles are 20, 19, 18, 17, 16, 16, 15. Do they continue to grow after trigger? Could the small ones be mature by Friday? So I think what you're saying, because today is Tuesday, unless you're in another country, that you're triggering tonight for a retrieval on Thursday. However, let's just say you're triggering tonight for your egg retrieval and your follicles look amazing. 2019, 18, 17, 16, 16, 15 tell me that you're probably going to get about 6 mature eggs. The answer is yes, they can grow after trigger. However, we determine the likelihood of maturity based on the size on the day of, you just said it there. I mean Thursday retrieval. Thank you for that. Next question is, how common is a cyst after a fertility cycle using letrozole? I would say there's about a 90% chance you won't have it, a 10% chance you would. Hi, Dr. Amy, what's the reason for using aspirin and Medrol in a FET protocol? Do you recommend it for everyone? And the answer is, for me, I do. It's just kind of how I was trained and something that I always do. I use aspirin because it makes me feel better about using estrogen in patients and also it allows me to prevent them from forming a blood clot. High dose estrogen, and that's what we use to get the uterus ready, can increase someone's risk of having a blood clot, and taking aspirin makes me feel a little bit better about preventing that. Aspirin can also prevent preeclampsia, especially in women who are over the age of 40, BMI over 30, or women with multiple pregnancies. We know that if they start it by 12 weeks of pregnancy, it can prevent preeclampsia. So I think it's a good thing to take in most IVF pregnancies. Not all. I think that in some patients, for example, patients who have reflux, gastritis, GERD, for example, it might not be a good idea. Medrol is something that can reduce inflammation. It hasn't necessarily been shown in robust scientific studies to improve implantation rates. However, it is something that I tell patients is optional, and I use it for everyone. However, if they have side effects from it, like a red face, facial swelling, if they wake up in the morning, they look like a tomato, it's time to stop it, because that can happen. This next question is, how many days of estrogen do you usually give before starting progesterone on a frozen embryo transfer? What dose do you start with, 2 milligrams or 4 milligrams? Can you share with us what your standard approach is for an FET? So for estrogen, I use usually 8 milligrams twice a day, or 6 milligrams, or I should say 2 milligrams 3 times a day. So I either have patients do 8 a.m. and 8 p.m. And when I go like this, it's 2 tablets of 2 milligrams at a time, or 1 tablet, 8, 2, and 8. So that's how I dose it. If you're someone who's sensitive to the pill and you don't like swallowing things, you then put the pill in your vagina. Alternatively, you can put a little sticker called a Vivel patch on the skin of your tummy, and that's estradiol as well. For patients who might need a little bit of something, we then put it in the butt. And I usually say here, we usually don't put anything in the butt here until transfer. And then you can do it that way. Next question is, hi doc, I still have 1 embryo from 2019. Result is day 6, but PGT abnormal, possible mosaic. Should we let's see here, transfer the embryo? What type of test for this embryo? Thank you. So the answer is talk to a genetic counselor, talk to the genetic testing company, talk to your fertility doctor, and then make a decision as to whether you should transfer the embryo or not. Last thing I want to put patients through is a miscarriage. So if your doctor feels that it doesn't make sense to transfer it, then I would say it probably is not a good idea, but listen to your gut and see what you want to do. Let's see here. Next question is, how to thicken the uterine lining. Things that I do are to make sure patients are active, exercising, eating well, decreasing stress, sleeping well, using different forms of estrogen. There's so many ways of doing it. Add L-arginine, vitamin D, E, I should say, and certain other things can help, like HGH, HBOT, which is hyperbaric oxygen therapy. Again, outside the box. Some people think it's weird. That's okay, but I have seen some good results with that. Let's see here. Next question is, hi, Dr. May. I just had my retrieval on Saturday, but I've had a fever since that day. It was 102 and has since lowered to 99. Is that normal? The nurse didn't seem to be too worried. So if your temperature is 99 right now, I would say that is not a fever, but I would definitely get tested for COVID and make sure you don't have COVID. That would be the number one thing for me. As long as you don't have any of their symptoms, I'm not worried either if the nurse isn't worried. But if you have abdominal pain, a foul-smelling discharge, a headache, any other symptoms that would suggest something that's concerning, I would definitely get checked out by your primary care provider. Next question. I recently had a hysteroscopy. My doctor said my cavity looked normal, but there was some stringy cobweb-like tissue that he removed. He said there's no name for something like that, but he has seen it before. Have you seen such a thing? What is it from? So stringy cobweb-like thing is also known as scar tissue, and there are different textures to scar tissues. That's probably what he's describing, and it is something that I've seen before. Let's see here. Is there any connection between Rh negative blood type and autoimmune miscarriages? And the answer is no. Let's see here. I'm 31, sorry, I have an abnormal chromosome and I don't know what to do about all of that. So I would talk to a genetic counselor if you have an abnormal chromosome analysis yourself. Then using IVF to test embryos for their chromosomes could be helpful to give you the highest chance of having a successful implantation and pregnancy. Next question is, I had a uterine polyp removed and biopsy showed small irregularities and the report recommended doing an endometrial biopsy. Does this mean I have precancerous cells or what does this mean? It's hard to say. The small irregularities should actually be described in very specific terms. Pathologists don't mess around. They actually use words that describe the cells that they're seeing, and there's a word that's going to go along with small irregularity. It just won't be small irregularities. You want to find out more about what those irregularities are. Next question, what do you do with your 40-plus-year-old patients for protocol start for IVF, birth control pills, Estradis, natural start, and why? So I tend to do a natural cycle start because every single egg matters to me. And if I start birth control pills, it can suppress the ovaries and make it harder for them to wake up. And you can imagine if someone has 5 eggs and I end up getting only 3, I'm going to be pretty upset because I want every single egg to grow. And so birth control pills can result in less eggs, and that's just pretty, that's just not ideal for me. My frozen embryo transfer is Friday. I'm doing Embryo and Prednisone because of my failed embryo transfer and TNFA gene mutation. When do you recommend Prednisone to your patients? Is there any bad side effect? And the answer is yes. Prednisone can cause insomnia. Some patients might have a hard time coming off of it. Very rarely, I mean super rarely, you can have this type of steroid psychosis. But we tend to use very low doses of prednisone in IVF. I tend to use Medrol rather than prednisone, and I only use it up until the transfer. Next question, should we continue NAD and pterostilbene through FET prep? And the answer is I do for patients of mine. Let's see here. How many eggs should I hope for my first IVF cycle? AMH is 1.8, AFC 12, FSH 9, I'm 38. And I would say probably 10 mature eggs, 8 fertilized, 3 to 4 blastocysts, and hopefully at least 1 to 2 that have normal chromosomes. Next question, hopefully you get to see my question. I had some mucosal fibroids removed, but the new doctor found a 7-millimeter intramural fibroid located on the back of the uterus and went to remove it. Does he have to? Does he have to? And the answer is yes. It would be awesome if he can. 7 millimeters is 7 millimeters. An embryo is microscopic. You can't see an embryo with your eyes. So imagine that embryo looking up at a 7-millimeter polyp. It's going to be like, or a fibroid, it's going to be like Mount Everest, that little tiny microscopic polyp or fibroid. You know what I'm trying to say. So please, get the polyp out of the way. Polly the polyp belongs in a jar, not in your uterus when it comes time to placing an embryo inside your uterus. Next question, what causes an anembryonic pregnancy from a PGT normal tested embryo? What is the chance of this happening again? I'm 26 and I have 4 normal embryos left. So I think sometimes inflammation in the lining of uterus can cause it, so rule out that by doing an endometrial biopsy and doing the Receptiva DX test and looking at endometritis. The other thing that can cause it is an embryo that's actually not genetically normal. So while the chromosomes might be normal, there could be other genetic things that are wrong with it. The other possibility is antiphospholipid antibody syndrome, a uterine septum, scar tissue. Those are the kinds of things that can also cause this, as well as adenomyosis. The other thing that I kind of think about in a case like this is that the embryo may not have been normal. While it had normal chromosomes, and that's what the report was, it could also have been mosaic. So mosaic embryos could result in anembryonic pregnancies as well. And I do think that you can have, what's the word I'm trying to use? You can be reassured that you gave your embryo the very best chance of implantation success. So I don't necessarily think that there's anything you could have done better or different, but talk to your doctor about the protocol to transfer, talk to them about the lining of the uterus and all the things that I just brought up. Next question, my follicle tracking showed at least 11 follicles up to trigger day, but only 4 eggs retrieved. AMH is normal, estrogen normal before retrieval. What do you think could have happened? So it could have been ovulation, not good enough trigger shot dosing, and maybe next time, better trigger shot timing, planning. Would you recommend Ovasitol for someone who doesn't have PCOS? And the answer is there are certain ways that Ovasitol can help in women who don't have PCOS. Sometimes women with endometriosis can benefit from Ovasitol. Sometimes women can have metabolic issues not related to PCOS, like higher insulin and glucose levels, who can also benefit from Ovasitol, and they don't necessarily have PCOS. Okay, the next question is AMH is, let's see here. AMH is normal for my age, estrogen is normal. What do you think could have happened? I only have 1 embryo day 5. I think I just answered that question. Has anyone heard of a long protocol with Menopur-only stem? And the answer is absolutely. You can do Menopur-only stem. I do quite a bit of that. And a long protocol just means taking birth control pills overlapping with Lupron, and that's quite a common schedule. Please recommendation, Dr. Orange County. So in Orange County, I love Dr. Banafsheh Kashani. She is wonderful. Kashani. Let's see here. My AMH and all other blood work looks great, but I was a poor responder to both rounds of stimulation, even when my medications were increased. I also take all supplements that are recommended. What else could get tested? We have male factor. So the other thing that you can consider doing is looking at how they started your stimulation. Did they put you on suppressive medications like birth control pills, estrogen priming? That might be something that your doctor might want to reconsider. It's also possible that trying a more natural cycle and doing, let's say, a hybrid cycle approach of fertility pills and injections might be better for you. You guys, I'm going to pop off. It has been awesome being here tonight. Thank you for sending in all your questions. Thank you for hanging out with me and live chatting with me throughout today's show. I love getting your questions. I'm humbled and honored to be able to answer them and be here every day to talk to you guys. So thank you again for joining me, and I can't wait to be back again. And you guys know you're going to see me here again soon. Have a wonderful night and keep sparkling. Bye, you guys.